And joining us now to talk about your health is Dr. Farinaz Seifi, a minimally invasive gynecologic surgeon at the University of Maryland Medical Center, also an associate professor at the University of Maryland School of Medicine. Doctor, thank you so much for joining us. One of the conditions you focus on is endometriosis. Tell us about that condition.
Thank you so much for having me. Endometriosis is when the gland of the uterus goes outside of the uterus and implants in the places that shouldn't be implanted, like ovary, bowel, outside of the uterus, in the peritoneal cavity, in the fallopian tube, and cause pain, chronic pelvic pain, and pain during intercourse, pain even during bowel movement, digestive issues, and infertility.
How common is it?
Endometriosis, before we were thinking about 5 to 10% of the women in reproductive age, now actually increased to 10 to 15% in reproductive age, and up to 3 million cases per year we diagnose in United States.
Do you think there's a reason why the condition itself is becoming more common, or is it being diagnosed more often?
I think it's being diagnosed more often. It's alert information and more knowledge that patients and medical professional is becoming more diagnosed.
You mentioned women of reproductive age. Within that large window, where does it tend to come up, and do we know about a cause?
Very good question. So endometriosis can come as early as adolescence age. When adolescence gets puberty and menstruation, endometriosis can come. It can come anywhere between age 15 to 50. The younger, the more risk. The older, less risk. Why this is happening? Nobody knows for sure. There are theories that maybe retrograde bleeding causing this, maybe genetic causing this. There are theories about environmental effect, but nothing is proven, and research is on progress.
So some women may feel it's just a difficult period. Is that something you hear?
Yes, definitely. First, let me tell you a message to every woman in the reproductive age. No period should be painful. That's not normal. That's completely abnormal. If you have a painful period, there is a reason for that. Not all the painful periods are endometriosis, and not all the endometriosis cause only painful period. So when you have a painful period, please seek medical advice from your OBGYN. And now, go ahead.
No, please.
And now, if the endometriosis is only bad period or pelvic pain during period, no. Can cause chronic pelvic pain, can cause pain during intercourse, bloating, constipation, diarrhea, nausea, pain during voiding and urination, all comes from endometriosis.
We mentioned in your introduction that you're a surgeon. Is that the only treatment, or when is surgery indicated?
Endometriosis is a multidisciplinary treatment. And the reason why we start from medical treatment. If medical treatment fails or patient is seeking infertility and the organ is affected by the endometriosis, like blockage of the fallopian tube, large cystic mass that is preventing her to get pregnant, then we go to the surgical management. Severe pain is another reason that doesn't respond well to medical treatment, and we proceed with the surgical management. We offer in University of Maryland, we offer minimally invasive procedures for all the endometriosis surgeries, including we perform neurolysis, which decrease the pain significantly. And one more message, that endometriosis surgery should be done by endometriosis expert.
And why is that? It's one of those things where somebody who does it twice a year may not be as speedy, or may miss some things that somebody does it, every week would catch.
So if the endometriosis surgery not done well at the first attempt, it will increase the risk of future fertility and future surgeries. So it means that if we fail to remove all the cystic mass of the endometriosis in the first attempt, we should go back in 2 months and 3 months and remove the other part of it. And that will damage the ovarian reserve. That would actually put more harm to fertility than helping the patient.
I've read that hysterectomy is sometimes indicated. When is it necessary? And for people who are who would like to still be fertile, can that be put off?
Definitely. Hysterectomy is a last resort, and nobody can guarantee that even with hysterectomy, we can treat the endometriosis. So please say no to hysterectomy. There are more options, even surgical options, that other than medical options, to remove the endometriosis, to ablate them with the laser argon surgically, and to excise all the endometriosis nodule, to release the nerve that is affected by endometriosis. And there is no way that we can guarantee that hysterectomy will solve your problem. Just keep it as a last resort.
Are there degrees of the condition, mild, moderate, severe? And if there is such a thing for somebody with mild endometriosis, would it tend to progress over time?
There are a staging for endometriosis, and that depends on how many nodules, what is the size of endometriosis nodules, and where is the endometriosis. The degree is different. It doesn't matter what degree you have, that matters for us as a surgeon to compare it for the next step. But even patient with a mild endometriosis can have severe pain, and patient with severe endometriosis can have mild pain. Mild endometriosis can progress to severe endometriosis, so the early diagnosis and early treatment is essential.
We're talking about minimally invasive procedures. That obviously means no big incision. What's the advantage to the patient? I'm imagining less pain, maybe a shorter time in the hospital.
So minimally invasive procedure, actually, we combining with the enhanced recovery after surgery, means that patient can drink up to 2 hours before coming to hospital. After the surgery, even after hysterectomy with a minimally invasive procedure, they can go home the same day. They can rest in their own bed with their own family and have a comfort of their own home. Their return to work is significantly shorter than open procedures and more traditional procedure. Other than most of our patients doesn't even need narcotic medication. They don't even use oxycodones that we give 5 or 6 oxycodone patients. They don't even use it.
Starting point for a young woman who has some of the symptoms you described would be your local OBGYN, if you have such a relationship?
Yes, definitely. Any abnormal menstruation, any abnormal pain you have, please describe it to your OBGYN. All the pain should be heard by us. And then if there is a suspicious for endometriosis, please ask for referral for the endometriosis experts.
And what do you think is next in terms of frontiers in medicine? What do you think is on the horizon?
So there are very good advanced research on the level of gene and also at the level of diagnosis of endometriosis by blood tests, by saliva tests. And so that will actually help us to diagnose endometriosis as soon as possible.